So as I mentioned, pneumonia presents with fever and reproductive cough. So let's see a case of pneumonia. This is a case of bilateral round pneumonia, an adult patient with long history of smoking, presents with fever and cough. This is a chest radiograph, frontal and lateral view, and this is the CT scan. So the chest radiograph showing bilateral mass-like opacities with right paratracheal lymphadenopathy. Chest radiograph showing bilateral mass-like opacities with right paratracheal widening, indicating right paratracheal lymphadenopathy. But there is no pleural effusion. CT scan demonstrates the characteristic air bronchograms within the opacities. The consolidation on CT has taken a lobar pattern. This is the CT scan. The characteristic air bronchograms within the consolidation, and the pneumonia has taken the lobar pattern. This is the right upper lobe, and this is the left lower lobe. At the level of the tracheal bifurcation, the lung should be divided into upper and lower lobes. At the level of the tracheal bifurcation, the lung should be divided into upper and lower. This is community-acquired pneumonia. Community-acquired because the patient is not admitted to the hospital, so this is community-acquired pneumonia, tend to be symptomatic with fever and cough, as I mentioned. Pneumonia often presented with air bronchograms on CT scan. Management: the patient should start the antibiotic treatment and follow up chest x-ray within 2 weeks. If the symptoms and radiographic findings did not resolve after treatment, think of other pathology as lung cancer. Costochondritis causes chest wall tenderness. Pulmonary embolism is rare in adolescent without risk factors. This is an example of acute pulmonary embolism. The history here, 78-year-old man. That's why I mentioned that pulmonary embolism is not common in adolescent. It's common in older age with risk factors. The risk factor here is high-grade urothelial carcinoma. This patient has malignancy, presence with dyspnea. So any patient with a history of malignancy and presence with dyspnea, think of pulmonary embolism. CT angiography of the pulmonary arteries show intraluminal filling defects, expanding the lower lobes. Pulmonary arteries, expanding the lower lobes, pulmonary arteries. At the level of the heart, the lung should be divided into middle and lingula. lower loops, right lower and left lower loops. So there are intralaminar filling defects expanding the lower loops, the lower loop pulmonary arteries. The interventricular septum is bowed, and the bowing is toward the left ventricle, suggesting right ventricular strain. The right ventricular strain means right ventricular dilatation without hypertrophy. Lung windows reveal peripheral wedge-shaped consolidation and the ground glass opacities. The lung window reveals peripheral wedge-shaped consolidation and the ground glass opacities, suggesting pulmonary infarcts. Differential diagnosis of intravascular filling defects: pulmonary embolism, sarcoma, pulmonary artery sarcoma, tumor emboli. The most common underlying factors for pulmonary embolism is prolonged embolization after surgery and malignancy. D-dimer has high sensitivity but poor specificity. It is used only to exclude pulmonary embolism. Signs on the chest X-ray include the Wester mark sign, which is decreased vascularity in the peripheral lung. Fleischner sign, which is enlargement of the central pulmonary arteries. Hampton sign, which is pleural-based areas of increased opacities. Pulmonary CT angiography is the gold standard of diagnosis. Right ventricular strain is an associated finding of massive pulmonary embolism, manifested as right ventricular enlargement without hypertrophy. Management for massive pulmonary embolism that causes systemic hypotension is thrombolysis and thrombectomy, with prophylactic management including prophylactic anticoagulant, which is the mainstay of treatment, and prophylactic inferior vena cava filter placement. So pulmonary embolism is rare in adolescents without risk factors.